Okay, so when you see acid-fast bacilli on a test or out in the clinic, your brain probably immediately screams tuberculosis, right? But, well, not all acid-fast bacilli are actually TB. Today, we're bypassing standard tuberculosis completely to tackle the deeply tested, super high-yield world of non-tuberculous mycobacteria, or NTMs for short.
Welcome to this explainer. I am so excited to be your guide today because our goal is pretty simple. We're going to help you completely crush your board exams using a pattern recognition approach to NTMs. We're building a high-yield study review together that's going to make these complex bugs literally unforgettable.
So here's the structure for our masterclass. We'll hit the ground rules of NTMs, meet the pulmonary heavyweights, explore skin infections and rapid growers, navigate some really tricky diagnostic traps, and then finally decode the immune pathway defects. Let's dive right in with Section 1, the ground rules of NTMs.
Before we go memorizing specific diseases, we kind of need to strip away the mystery of what these organisms actually are. There are over 199 species of NTMs out there, and they are everywhere, completely ubiquitous in soil and water. But the absolute core board fact you have to remember is that unlike TB, there's almost no human-to-human transmission of NTMs. Think about your next hospital rotation. Unless you're dealing with a patient with cystic fibrosis, these bugs just don't spread from person to person. Instead, they attack when defenses are down. They require some sort of host impairment, which leads to disseminated disease, or a physical breach like an inoculation to cause an infection. And surprisingly, here in the US, pulmonary NTM disease is actually more frequent than pulmonary TB.
Moving right along to Section 2, the pulmonary heavyweights. Let's shift our focus to the two biggest players causing lung infections.
First up is Mycobacterium avium complex, or MAC. And this brings us to a huge classic exam buzzword, Lady Windermere syndrome. If your clinical vignette describes an older, non-smoking white woman with a tall, thin body habitus and chest wall abnormalities, we're talking scoliosis, pectus excavatum, or mitral valve prolapse, you should immediately be thinking of MAC. On imaging, you're looking for nodular bronchoectasis, specifically in the lingular and right middle lobes. That specific anatomical location is an incredibly high-yield detail for the boards.
And comparing these two heavyweights really highlights the differences you need to know. While MAC gives you that right middle lobe and lingular nodular bronchiectasis, our other heavyweight, M. consacii, does something totally different. M. consacii is literally the ultimate TB mimic. It presents with upper lobe cavitary lung disease and hemoptysis. If a case looks exactly like TB, walks like TB, but the bug is definitively an NTM, your answer is M. consacii.
All right, let's leave the lungs behind for Section 3, skin infections and rapid growers. We're looking at some bizarre cutaneous syndromes and species that grow incredibly fast.
Let's define an extremely testable cutaneous syndrome, fish tank granuloma. This is caused by M. marinum. The patient history here will always involve an aquarium, a swimming pool, barnacles, or maybe fish scales. It typically presents as papules or ulcers on the hands, but here is the kicker you need to watch for. It features a sporotrichoid spread right up the arm following the lymphatics, and it often causes tenosynovitis, which impairs the patient's manual dexterity. Oh, and note this absolutely crucial lab clue. M. marinum uniquely grows at exactly 30 degrees Celsius.
Let's rapid fire through two more really unique bugs. M. ulcerances causes the Bernoulli ulcer, which is commonly seen in tropical Africa. It creates a completely painless, clean, sloughing ulcer. Now, why is it painless? Because it secretes a mycolactone toxin that drastically suppresses local inflammation, leaving a clean-looking wound but hiding a severe, deep risk of osteomyelitis right down to the bone. Then we have M. hemophilum, which causes skin infections in immunocompromised patients. Just like the name suggests, it uniquely requires iron or blood supplementation for culture growth.
Next up, we have the rapid growers. These are defined as taking less than 7 days to grow in the lab. You really need to know two main ones here. M. abscesses is notorious. It's a huge barrier for cystic fibrosis patients, and interestingly, it's strangely associated with esophageal motility disorders like achalasia. It causes a pulmonary disease that is very difficult to cure. Then there's M. fortuitum. The classic board vignette for this one is a skin infection following a pedicure bath, especially if the patient shaved their legs right before. Yes, that is a classic board trap. It's also linked to post-surgical and IV catheter infections.
Okay, let's build out a mental cheat sheet right now to lock this all in. We've got MAC associated with soil, birds, and Lady Windermere. M. canzanzii coming from water supplies to mimic TB. M. marinum from fish tanks. M. abscessus as the rapid-growing nightmare for CF and achalasia patients. M. ulcerans causing those painless Bernoulli ulcers. M. fortuitum lurking in pedicure baths. And one more geographic clue to add to your mental map. M. zenopi or M. malmoense. If a vignette mentions hot water pipes and a patient in Northern Europe, that is your target for sure. Let's transition into Section 4, the diagnostic traps. Recognizing these syndromes is great, but knowing when not to treat is what really separates the novices from the experts.
I want to pose a classic clinical question to you. Think about this. If you isolate an NTM from a respiratory specimen, do you immediately start treatment?
The answer? Absolutely not. NTM isolation does not equal NTM disease. Because these organisms are literally everywhere in the environment, you have to be super careful when interpreting respiratory specimens. For example, if you see M. gordona pop up, beware. It is famously known as the tapwater bacillus and is almost never a true pathogen. To actually diagnose pulmonary NTM disease, you must meet strict American Thoracic Society criteria. You need the appropriate clinical and radiographic setting, and you need robust culture evidence. That means you need either 2 out of 3 positive sputum cultures, or 1 positive bronchoscopic wash or BAL culture, or a tissue biopsy showing a granuloma or acid-fast bacilli along with a positive culture. You just cannot pull the trigger on treatment based on a single random sputum sample.
Okay, here's another massive trap involving IGRs, the blood tests used to screen for latent TB. 3 specific NTMs will cause a false positive IGR test: M. marinum, M. kansesi, and M. schulgi. Why does this happen? Well, because these 3 bugs actually share the exact same ESAT6 and CFP10 genes as standard M. tuberculosis.
When you do definitively diagnose and treat, there is one unbreakable ground rule. Never, ever treat NTM with single drug therapy, or resistance will rapidly emerge. For MAC, the standard is triple therapy, a macrolide, ethambutol, and a rifamycin for over 18 months, and you always need to test for clarithromycin susceptibility first. For M. kansesi, you're going to use INH, rifampin, and ethambutol for 12 months after the cultures finally turn negative. And for the notoriously difficult rapid grower M. abscessus, you will absolutely need an expert consultation, a macrolide plus some heavy-duty IV drugs like amikacin, acarbapenem, cefofoxacin, or tigecycline.
Now, I want you to focus on this single number, 50. Why is 50 so important here? Well, if an HIV patient's CD4 count drops below 50, that is the specific threshold where they are at high risk for severely disseminated MAC disease, presenting with fever, weight loss, anemia, and organomegaly. At a CD4 under 50, prophylaxis is absolutely required, which is typically going to be weekly azithromycin or daily clarithromycin or rifabutin.
This leads us perfectly into our final topic, Section 5, the immune pathway defect. We know what happens in HIV, but what happens genetically when a non-HIV patient's body just can't fight back against NTMs?
Let's walk sequentially through how a healthy immune response actually clears these bugs. To clear an NTM, a very specific chain of events has to happen. First, a macrophage phagocytoses the Mycobacterium. Second, that macrophage produces interleukin-12. Third, that IL-12 stimulates your T cells and natural killer cells. Fourth, those cells then produce interferon gamma. And fifth, that interferon gamma circles back and activates the macrophage to finally kill the bug. This is the absolutely crucial IFN gamma/IL-12 pathway.
So, if a patient has disseminated NTM disease, but they don't have HIV or some obvious iatrogenic cause, you have to investigate this specific pathway for defects. A defect here equals severe vulnerability. This could be due to genetic mutations in genes like IFN-GR1, STAT1, or IL-12-RB1. But pay really close attention to this highly testable acquired defect, anti-interferon gamma autoantibodies. The classic clinical demographic for this is East Asian women. These autoantibodies completely destroy the pathway, leading to severe disseminated MAC or M. abscessus. And notably, this will result in an indeterminate IDRA test result, simply because that test relies on that exact interferon gamma response to work.
And that brings us to the end of our masterclass. You've memorized the bugs, the classic syndromes, those tricky diagnostic traps, and the strict treatment rules. But the real test of a master clinician is this. Can you look at a patient's presentation and spot the exact immunological failure before the lab results even return? Keep these clinical patterns locked in your mind, and you will absolutely crush this topic on the boards. Thanks so much for learning with me today on this Explainer. I'll see you next time.